Well, I know you guys are all ready after being in the cadaver lab, all right, to talk a little bit about CLTI. We talked a little bit about this morning getting into classification systems that's going to help us to communicate with across specialties. So as you see, a lot of specialties are involved, and I think, in being cardiologists or vascular surgeons or radiologists, you know one, but you need to understand all the different systems. So, I'm just going to go over a little bit here. As you know, peripheral arterial disease, we're here because it's growing rapidly with an aging population, right? And so therefore, and a lot of these patients have profound medical comorbidities, such as diabetes, hypertension, hyperlipidemia. But classification systems have evolved, just like our patient population has evolved in terms of who we're treating with CLTI, right? So when you look at a classification system for PAD, you want to take into consideration a few things. So one is, what is the clinical presentation and symptoms? Two is, what is the physiologic evaluation of this patient? Three is, what is the anatomic pattern of the disease that you're dealing with? And then you want to integrate both the physiology and the clinical classification into a system that's able to communicate to whoever you're talking to about what the status of the patient is. So I want you to actually think about it that way, right? So when you look at clinical symptoms, obviously you have asymptomatic and symptomatic, but we're going to talk about symptomatic patients, and you want to drop them down into claudication and then chronic limb-threatening ischemia, which is then further breaking down into ischemic rest pain and or tissue loss, okay? So 21% of claudication patients will develop CLTI within 5 years. Arguable statistic. I can show you statistics that'll say only 5% will. But once you get to ischemic rest pain and tissue loss, 25% of these patients will suffer amputation at 1 year. And of course, as we know, those of you who are cardiologists, 22% at risk for mortality at 1 year. Okay, so physiologic evaluation, obviously you're going to need ankle brachial indexes to go ahead and put them into categories. Obviously, mild, moderate is 0.7 to 0.9. Again, the waveforms are on the side. Generally, they're biphasic with a strong biphasic upstroke and downstroke, or they can also be weak biphasic as you get closer to 0.7. Severe is usually generally patients who have pain and ulcers. It's usually around 0.3 to 0.5. You get monophasic and high monophasic or dampened monophasic waveforms. And critical limb ischemia is generally less than 0.3. Again, these patients will have advanced ulcers or gangrene. But again, remember, it's a spectrum of presentation depending on what you see and what test is done. So remember, toe pressures are important, and it's important for you to see that especially in diabetic disease and advanced disease, you have to use toe pressures. The reason is calcified vessels spare our digital arteries, and therefore, because of that, you can use a toe pressure. And when you use the waveform and the pressure, if you have a pressure greater than 40 millimeters, then clearly our diabetic and ESRD greater than 60 millimeters are normal. However, if you have infection control and wound care and offloading, you can try to achieve this in order to be able to heal the wound. So again, it's very, very important. You can see here, as you can see, the non-compressible vessels show that the systolic pressure can be very, very high in these particular patients. So again, I mean, there's a busy one, but this is by Liz, who's going to be here tomorrow, basically showing how the toe pressures are really predictive in diabetic versus non-diabetic. And 45 and 65 seem to be the cutoff number with a reasonable specificity and sensitivity as a threshold for wound healing. So now what about the anatomic classification? So you put them into a physiological classification based on the pressures and the ABIs, and anatomic you can use TASC. Now TASC, again, it's a dated way of classifying these patients, and generally is used more for research, but again, it's always good to go ahead and do it. And again, it's beyond the scope of this talk, but you need to start understanding what's a TASC B lesion, what's a TASC A lesion, what's a TASC C lesion, and a TASC D lesion based on the area which you're treating. You have TASC lesions for both the iliac, the SFA, and the below knee, so it's very, very important as you guys start to talk. And in general, TASC A and TASC B lesions are generally more simpler lesions and not associated with more complexity and intervention, but TASC C and TASC D are also more. Now, another way is looking at as the TASC 2 document, which basically, again, classified this further into below knee based on the pattern of disease. And the length of disease to, again, go ahead and talk about the complexity of disease. disease. And again, the same thing occurs when you go task A to task D. The complexity, the length of the occlusion, the calcification, all also changes. The other thing is the GLASS, or the Global Vascular Guidelines on the Management of CLTI. This is another one. And then this also looks at critical limb ischemia and chronic limb-threatening ischemia. And the reason critical limb ischemia was that critical limb ischemia was used to indicate patient who was at risk of limb loss with either rest pain or wound. But what happened with the chronic limb-threatening ischemia, they made a new change in the vasculature or the nomenclature to look at the continuum of limb-threatening disease that may start at claudication and then end up at critical limb ischemia. Generally, to show that there's a progression pattern of this disease in patients with the risk factors for limb ischemia. So ischemic rest pain or non-healing wound with evidence of PAD, acknowledging that patients with diabetes have other underlying factors that predispose to impaired wound healing, and eliminating a cutoff for intervention. So you're looking at the spectrum of disease and taking into consideration the patient factors as well as the disease factors or the anatomic factors to see how these patients are going to end up doing. There's also other anatomic disease pattern. The GLASS, which is a global limb anatomic staging system, is a clinically oriented framework for classifying the pattern of arterial disease in CLTI, and successful revascularization in CLTI always nearly requires restoration of pulsatile inline flow to the foot. And I think that's very, very important because successive endovascular intervention is largely defined by the complexity of atherosclerosis within the anticipated arterial path and in order to be able to provide inline flow to the foot. So GLASS is based on defining the tap or the targeted arterial path in each individual artery by high quality imaging and requires selection of preferred infrapopliteal artery. The targeted arterial path is generally selected on the basis of the least diseased crural artery providing runoff to the foot. So basically getting straight line flow into the foot, okay? Let me go forward here. So again, it's another classification system, again, that's used for research. We talk a lot about it in conferences. Again, the staging system, it goes from 0, 1, 2, 3, and 4. And of course, depending on the artery and what type of occlusion it is, you can go ahead and understand that as you get closer to 4, it becomes a more complex lesion than not. Again, and then you have the anatomic. Again, we talk a little about both tibial as well as in the SFA. Again, when you look at the inframalleolar distriction, you have P0, P1, and P2. Again, looking at the types of different perfusion into the foot, and also what are the target artery which you're going to go for based on how it crosses the ankle into the pedal arch. Again, this is a femoropopliteal grade and an infrapopliteal grade and different things that you need to know, and these are the GLASS scores. So what about the Wi-Fi system? And I think this is probably the most commonly adopted system because this is a system that really looks at wound, infection, and flow. And I think this is a system that works well because it's also been adjudicated with amputation-free survival. Dr. Mills actually pioneered this and actually has validated it now. And it's really become the way we're now discuss these patients. You'll see tomorrow and day after as we perform and we present these topics, you'll see that the Wi-Fi system will often be used. Again, you can read about it on your own. Again, you have grade 0, 1, 2, 3, and 4 based on the ulcer and the gangrene. And then obviously you also have your ABIs and your ankle systolic pressures and TCPO2. So again, you also have, like I said, you also have to take into consideration infection as well. And it goes into this nice little chart, and then it'll give you your Wi-Fi score, which you can correlate the score with the opportunity of wound healing and limb loss. So another way of increasing your sensitivity and predictive values, combining GLASS and Wi-Fi to determine what's the best therapy for the patient. Obviously, depending on the GLASS and the Wi-Fi category, you can decide that what's best for the patient, whether it's open bypass, intermediate, or endovascular, or just don't do any intervention at all. So again, if I was going to sum it up in the last 20 seconds, clinical suspicion of CLTI, rest pain, or tissue loss, you always want to do a complete physical exam suggestive of PAD. If you've got that, you want to measure the ABI and the Doppler waveform. If it's an abnormal ABI, you want to measure your toe pressures, TBIs, and Doppler waveforms. And then you definitely want to stage the patients generally with Wi-Fi and then determine how you want to do. So obviously if it's a normal ABI, you're going to go down a different pathway, but I think this is kind of a suggested algorithm that you can do. Again, I thank you for your time. Thank you.